Today, oh yeah, thanks, Liz. Today we have Dr. Kajsa Vlasic presenting about some of the pediatric emergency medicine and burn work that she and her mentor, Dr. Liz Keating, one of our faculty, have been involved in Tanzania. Dr. Vlasic is a Utah native and knows a lot of folks here, and but did her pediatric training out in Philadelphia, I believe, and then moved back to Utah to do her fellowship. So she's going to tell us a little bit about what her work is and where it's going. And for context, Dr. Keating is a relatively new faculty in the Peds EM group at Children's, and also just got a major NIH award herself to do trauma systems work with colleagues at KCMC in Tanzania. So phenomenal leaders here for us to learn from. So welcome and thanks, and take it away.
Great. Thanks so much for having us. It looks like Liz Keating just jumped onto the call as well. So I'm happy to have her here along with a lot of other mentors who've influenced me across my career, back all the way to my soccer coach from youth, Ray Price. So I'm going to pull up some slides and we'll go through. I'm hoping to use this time really to discuss a work in progress, or to do a work in progress presentation and discuss my fellowship research project, which is based in Moshi, Tanzania, and is adjacent to a lot of the work that Liz Keating has been doing there and is continuing to do with her NIH funding. Just as background, so I am from Salt Lake. I went to medical school here and did go to Philadelphia and did my pediatrics residency training at St. Christopher's Hospital for Children. And I came back almost 2 years ago, and I'm currently a second-year fellow at Primary Children's Hospital, and I am doing a combined fellowship in pediatric emergency medicine and global health. So I've committed to a 4th year of fellowship training to accommodate that. So alongside my clinical training, I am pursuing a master's in public health from the London School of Hygiene and Tropical Medicine. And I am lucky enough to have support to essentially spend 2 chunks of time each year on site in Tanzania. So I'll be heading back there shortly in about a month to continue the next phase of my project. But I've been there every 6 months, anywhere from 4 to 6 weeks at a time. And I'm excited to be establishing that as a site alongside Liz. Let me pull up my slides. We can get going. And Liz Keating is my main mentor on this project. And I'm glad she's here because I think as we get into kind of details moving forward and discussion at the end, I'd love to have her input. Can you guys see like a typical slide deck on your screen? Okay, awesome. So my overall study title is Predictors of Morbidity, Mortality, and Care Delays amongst Pediatric Burn Injury Patients in Northern Tanzania. And this is a mixed method study. And again, this is a work in progress. I'm still in the midst of it. So happy to have any ideas, thoughts, questions at the end to kind of propel this forward in a productive manner. Financially, I just want to disclose that the pilot data for the study that I'm going to be discussing as part of my introduction was supported by Liz Keating's NIH Fogarty Fellowship, which she had successfully a couple of years ago. And currently, this study is funded by a Health Equity Research Corps Fellow Pilot Grant from the University of Utah for this academic year. Just to start off, we'll have objectives, background. So we're going to start off with some background. I want to delve into a little bit more about the landscape of global pediatric injuries, and then also burn injuries in low and middle income countries. And then talk about the pilot data that Liz gained during her fellowship, or her Fogarty Fellowship, on pediatric injuries in Northern Tanzania, which was the basis of what my study is now, looking more into depth on burn-related injuries. I'll then talk a little bit more specifically about my project, including the aims. And as it's a mixed method study, we'll talk about the quantitative portion of the study as well as the qualitative study. I am further along in the quantitative analysis, and the qualitative is in process. And then I'll talk about the next steps and open it up for discussion and thoughts from the group. Before I get started, I did want to recognize that I have an international team of co-investigators. So alongside Liz, I'm supported by Blandina Mbaga, who is a professor of pediatrics from Kilimanjaro Christian Medical Center in Moshi. Melissa Watt, who is faculty here at the University of Utah. She's from the Department of Population Health Sciences and is really supporting me through the qualitative part of this study. Catherine Staten, who is from the Department of Global Health at Duke University and is one of Liz's primary mentors, and I've been fortunate enough to have her support my project as well. She also runs the Global Emergency Medicine Innovation and Implementation Research Center out of Durham, and has her she's involved in a lot of projects in a lot of different sites, but all emergency medicine related. And then Teresia Mwakembe, she's the general surgeon who focuses on burn injuries and runs the burn center at KCMC, as well as Francis Sakita, who is an emergency medicine physician at Kilimanjaro Christian Medical Center, and has been involved in all of Liz's prior work as well. So I wanted to just start off and recognize that pediatric injuries and the burden of them have increased significantly over recent years. And that's really, I was really excited that this is something Liz is interested in evaluating and something that I've thought a lot about. My interest in trauma and injury-related research really stemmed from my experiences living in Philadelphia and taking care of kids in the inner city who are exposed to a lot of physical trauma, a lot of emotional trauma. And I find the emergency department to be a unique location to really potentially, improve outcomes, but also just work with families and work with children as they're dealing with what could be devastating experiences. Based on UNICEF, a child living in a low-income country is 8 times more likely to experience an unintentional injury than a child living in a high-income country, based on recent research. And a lot of this is due to increasing urbanization, increasing globalization. In Tanzania specifically, there's been a lot of research on motor vehicle accidents and the impact of that on trauma in children. And so this is not seen just in Tanzania, but something that we're seeing globally. If we look a little bit more globally as well, injuries are a leading cause of death in children worldwide, and pediatric injuries are increasing globally. More than 95% of these injury-related deaths, though, for children are occurring in low and middle-income countries. So while we see a lot of trauma here in the United States and in other Western countries and high-income countries, the burden is really on countries that are classified as low and middle income. And there is a disproportionate burden in sub-Saharan Africa that has been well-defined in previous studies. There is, however, limited data existing on how children are cared for in a trauma sense, as well as their outcomes in low and middle income countries. So while we know that it's existing, we don't know what's happening or how the outcomes are and why the outcomes are the way they are. And few pediatric injury registries exist in low and middle income countries. I think this graph here on the right is nice in that it just kind of shows how big of a burden injuries are in its impact. So this is looking at children and really mortality related burden. And you can see that injuries make up almost 33% there of the pie chart. And that has been growing in recent years. It used to be that infections really took a toll on children and were a large proportion of their burden of mortality, as well as morbidity. But we now know that injuries there are more injuries now than HIV, TB, and malaria combined in terms of burden on children. And so that there's been a big change. I think a lot of that goes back to implementation projects from the WHO in the 70s and 80s, really trying to get a hold of vaccine efforts, antibiotics, oral rehydration solution, things like that to help children survive, particularly in the under 5 age group. So Liz went ahead and went to Tanzania to start a pediatric injury registry because a lot of these don't exist, and did this at Kilimanjaro Christian Medical Center in Moshi, starting in November 2020. And enrollment is still ongoing for this registry, and we now have over 900 patients enrolled. And from that data, she found that the highest mortality was amongst patients who presented with burn injuries out of all of the injury types that were presenting. I want to jump a little bit into the site of KCMC and what we see there and what the hospital is able to care for before we dive a little bit further into her pilot data. KCMC is located in Moshi, and Moshi is actually at the base, the foothills of Mount Kilimanjaro. So there's a lot of traffic from travelers who are heading up the mountain and traveling through the northern part of the country. But it's also there's a lot of people that live in this area. It's the zonal tertiary referral hospital for this part of the country, and it has an approximate catchment population of 12 million individuals. And the hospital itself is pretty well supported. It has an EMD, so an emergency medical department, has an operating theater. It does have a specialized burn center, also has CT and MRI capabilities, pediatric inpatient wards. There's a PICU and a surgical ICU, as well as a NICU, and there is subspecialist care. The subspecialist care isn't always there. Sometimes there's relying on people coming from other hospitals to provide support. And so it might not be consistent, but there is availability of subspecialist care, both for adults and children. And the annual pediatric ER volume is 1,400 to 1,700 patients per year. If you look on the map here, this hospital really takes care of all these little, or all these districts. And so it's a vast area. And this area is both rural, as you can imagine, lots of people who live truly in the foothills of the mountain, but also an pretty significant urban population. And I would say a growing urban population as well. There's, like we are seeing all over the world, there's movement of people towards the city for support and job opportunities. And again, with that urbanization and globalization from that perspective, that impacts potential injuries that people are seeing just from living in a big and busy city. I just thought I'd just throw in a couple more pictures of what life is like in the city. There are big markets where we get food and fresh produce all the time that's grown in the area. There are a lot of cars. There are electric tuk-tuks or rickshaws around, and lots of bikers and motorcycles that transport people where they need to go. This is the hospital from the outside. This is the front campus up on the upper left there. There is no actual pre-hospital like EMS type system in place. There are some private ambulances that exist, but nothing like we see here in Salt Lake City or in the United States that's well defined. So you'll intermittently find an ambulance, but it's not something that's relied upon in terms of transport for patients to the tertiary hospital. This is the corner of the ER that takes care of children, and there are a couple of beds in that space. When children are not in the emergency department, that space will oftentimes be filled up with adults as well. So they definitely are moving patients around to try to accommodate them as they come in. So back to Dr. Liz's pilot data. She published a couple of studies. The first one here, coming from the African Journal of Emergency Medicine, showed that of her initial registry data, the overall in-hospital mortality rate of children who came in with injuries was 8.2%. And 43 of those children who died in the hospital had an initial presentation of a burn injury. So this is where really my project started. And her initial descriptive analysis showed that burn severity was associated with increased mortality risk. She also published a paper applying the 3 delays model, which was initially created for maternal access to maternal care, and has been also translated to neonatal care survival, but now is being applied, I think, to a lot of different settings because we're seeing it as an impressive model that really describes potential delays to getting to appropriate care. And so using that model, she found that there were many delays in reaching this tertiary hospital that could be contributing to higher mortality for our pediatric burn patient, I should say pediatric patients with injuries. So pardon that error there. Home first aid being one of them, and a lack of knowledge of when to present were really big things that came from the qualitative studies that she was doing with caregivers who discussed how they came to the hospital and what potentially led to delays. There is some other information that exists out in the ether of literature related to burn injuries and LMICs. So again, burn injuries disproportionately impact children in LMICs. We know that the highest incidence is in sub-Saharan Africa. And globally, the mortality rate of burns in children is 7 times higher in LMICs than in high-income countries. There's good evidence that there's potential for lasting effects on the quality of life for those who survive their burn injuries when they don't have access to appropriate follow-up care and rehab. And while the study of pediatric injuries in general is increasing, the evaluation of pediatric burn injuries specifically is quite limited in this setting. There have been some other studies from sub-Saharan Africa that have shown similar trends of the high rates of pediatric burn injuries. There's some that have been have discussed home first aid efforts and what those look like and delays to care. There was one study particularly that came out of Malawi that found high rates of treatment from traditional healers as part of the pre-hospital component of care. that was associated with both care delays to tertiary level care and high pediatric burn mortality, although the number of studies that really kind of delve into the use of traditional healers is quite limited. The one from Malawi is really one of the more prominent ones that exists. And there's limited qualitative data regarding what families and healthcare providers perceive related to burn injury and LMICs and how we can potentially impact the system from that level. So based off of Liz's pilot data that came from her Fogarty Fellowship, there's an obvious information gap that exists. And so we don't know enough about why outcomes are occurring poorly for children with burn injuries. There's not a lot of data about why the rates are so high. And so this seems like a pretty wonderful opportunity to delve into this problem a little bit deeper and work with the faculty at KCMC to understand this problem better and think about intervention strategies that might be effective at KCMC, potentially in Northern Tanzania more generally, and start further discussions about this moving forward. So my fellowship project currently has 2 study aims and likely will have a third coming up soon. From a quantitative standpoint, I'm looking to identify risk factors associated with poor outcomes in pediatric burn injury patients at KCMC, and I'll take you through the journey of what that's looked like over the last year since my project was started. And then the second, my qualitative aim is examining how caregivers approach the continuum of burn injury care for their children. So trying to better understand what care-seeking behaviors are like, what kind of care is received by patients prior to KCMC, and why those are chosen, barriers that impact the access to actually getting to the hospital and getting to definitive treatment, and if there are barriers within the hospital itself that potentially may impact patients from the family perspective. So this is outside of the burn unit. It's its own little hospital component on campus there. And I'll start off by diving a little bit deeper into the quantitative part of my project. So I initially wanted to evaluate if burn severity, age group, and sex were associated with in-hospital morbidity and mortality. And I did this by doing a retrospective observational study, but used the continuously prospectively enrolling pediatric injury registry data at KCMC, which has allowed me to, over the year, expand my group, which has been nice because that's a continuously growing cohort that we have in our registry data. The inclusion criteria is that patients are enrolled into the registry if they are less than 18 years of age and they are presenting with a pediatric or with an injury that occurred within 30 days of arrival. And so my inclusion criteria is that that initial presentation injury should be a burn. But otherwise, all this data is coming from the registry that Liz has started and continues to run. And I wanted to evaluate morbidity similarly to what Liz used. And so that is using the Glasgow Outcome Scale Extended, or the GOSE for short, specifically for pediatrics. And this is a previously validated tool that I'll explain a little bit more in the coming slides. And I did a very descriptive statistical analysis on this initial data looking at patient demographics, care details, and outcomes, and did run some logistic regression modeling that we'll look at. So for background, for those of you who are not aware of the GOSE score for pediatrics, this is a previously validated external assessment tool. And so what does that mean? It means that a researcher can determine a patient's capacity after asking a caregiver. So this is great when you're talking about children. And they can ask them a series of questions to ask about or to figure out the child's level of functioning. It encompasses most of the domains from the WHO's classification of functioning, disability, and health. And it has been recommended for use in trauma registries to monitor functional outcomes. It is an 8-item instrument, as you can see on the right there. And so we think of score 1 to 2, upper good recovery, lower good recovery, as a definition of good recovery, and then a score greater than 2 indicating poor recovery, all the way to a score of 8, which is death. My initial quantitative results were performed last summer, so July 2023. And at that time, we had 92 pediatric burn injury patients. I'll talk about where we're at now in a few slides, but we're currently at, I believe, 120. So we've gotten a larger group over the course of the last 9 months. The overall in-hospital mortality rate for these patients was 22.2% in that cohort, which is astronomical, right? That's a quarter of those patients are dying approximately. And the largest burden of injury is in the 0 to 5 year age group, which has been seen in other studies that have looked at the kind of baseline characteristics of pediatric burn injuries and LMICs. And females were just slightly over 50% in terms of burden compared to males, which I do find interesting because oftentimes pediatric injury studies will describe there being a higher male burden in children. But I think it'll just probably require some further probing in terms of our research, but I think there could potentially be some factors influencing why females are burned slightly more, in that they're in the kitchen, they're potentially around some fire or sources like that more so than male. But that's something that we'll continue to look at as we move forward. There was no association between age group and sex with in-hospital mortality or morbidity during that initial analysis, but there was, on closer evaluation, there was statistically significant association between burn severity, ICU admission, and an altered mental status in the emergency department defined by a GCS of less than 15 in being associated with in-hospital mortality. And burn severity and ICU admission were associated with poor recovery or a higher morbidity based on that GOSI-PED scoring based off this initial analysis. We then found that patients with severe burns had a higher mortality rate compared to patients with mild to moderate burns. And this was based off of the logistic regression that we did with 48.6% versus 7% with a p-value of 0.002, so far smaller than the 0.05 cutoff. And so the conclusion of this initial analysis was that, okay, so we know that kids, the mortality rate of pediatric burn patients at KCMC is high. And we know that burn patients coming in with large burns, altered mental status in the ED, and those who require ICU admission had poor outcomes and an increased chance of death. But like, what do we do about that? I would expect that, right? If a kid comes in with a large burn and does not appear well in the ED, I would be concerned about their potential outcomes. And it doesn't really help us from an intervention standpoint. So we went back to the drawing table and then progressed with a second quantitative analysis that was a little bit different. At that time, we decided to characterize the pediatric burn injury population presenting to the ED at KCMC in general. So really focusing on the ED and evaluating if there are specific factors from ED arrival that can help us in evaluating patients and their risk for potentially having poorer outcomes or having higher rates of in-hospital mortality. So really, like, if a kid comes in and we see these kinds of factors, we'll know, hey, they might need some more intervention. So we did another retrospective observational study, used the same inclusion criteria, but this time we tested for differences in burn severity, vital sign abnormalities upon arrival to the ED, and time between injury and arrival. So looking at delays to care, and compared that with ICU admission, morbidity, and in-hospital mortality. We then ran t-tests for continuous variables and Fisher's exact test for categorical variables, and created a logit, logit or logistic regression curve to estimate probability of in-hospital mortality and ICU admission based on the total body surface area burned. So when we ran this analysis, which was in September, we then had 99 patients. And again, the overall in-hospital mortality rate continued to be about 22%. And what we found was that when TBSA burned was 45 to 50% or greater, the probability of both ICU admission and in-hospital mortality was greater than 50%. This is the logistic regression curve that we created, which shows you that kind of 45 to 50% marker being the influx point on the curves, where there seems to be just a pretty significant increase in their probability of either having an ICU stay or in-hospital mortality. Of note, we wanted to make sure that not all of the patients who were admitted to the ICU were then dying, because then this data isn't particularly helpful. And while 14 of the 21 patients admitted to the ICU died, a third of them were admitted to the ICU and did not die. So I think that's kind of important context for looking at this graph here. I then spoke with Dr. Teresia, our pediatric burn surgeon, who mentioned that, as a team, if a patient has 45% or greater TBSA burn injury, they treat them palliatively. And this was something that she said without really knowing the data that we had produced based off of that logistic regression curve. And one of the initial questions that came from that discussion was, well, is this a self-fulfilling prophecy looking back at this, right? And so I've had some further discussions with her, and they're still ongoing about what palliative care looks like for these patients, because I think that looks different in different settings. And so far, over the course of our conversations, she has described palliative care really being a recognition from the care team that the chances of survival are quite low for these patients. And so they still treat them. They oftentimes still debride them and graft them if they're able to. They have conversations with the family about prognosis, and their perspective on caring for them really just recognizes that based on where they are and their resources, that there is a good chance that this patient will not survive. So I think that's important, again, context to think about, that they're still getting definitive treatment in many ways, but it's more of the approach that the care team is having that makes them palliative. This analysis also showed that significant factors found on ED arrival that were associated with ICU admission and in-hospital mortality were hypothermia and hypoxemia and a need for intubation. And significant factors found on ED arrival associated with a higher morbidity or GOSI score of 3 to 7, not including 8, which would be death, is hypoxemia and need for intubation. We then looked at delays to definitive care and found that the median time from burn injury to KCMC is 20 hours, which is a long time. And 25% of patients arrived almost 4 days after their initial burn injury. That 4-day cutoff was selected looking at our bell curve. So that's where that number came off of. And I'm going to open up to some discussion later on how we want to define a delay to care for burn injuries. But in this particular analysis, using that 4-day cutoff, mortality was 33% in those who arrived roughly 4 days after the injury, compared to 19% in those who had arrived before that 4-day cutoff. This was not statistically significant, but we're going to rerun. We're actually in the process of rerunning that currently to see with a larger group if the power increase will help with the significant component there. So the conclusion of this analysis, this pretty descriptive analysis, again, is that our in-hospital mortality rate is high, and that the findings suggest that patients who have large burns, who are delayed on arrival to the emergency department, or really if they have really any vital sign abnormalities, should receive some form of prioritized care, because when they get to the emergency department, because delaying their care further really increases their chance of both morbidity and mortality, and that's our ultimate thing that we want to prevent. Again, we're in the process of rerunning this with a larger cohort, as this was last done in the fall, and we now have 120 at least enrolled as of last week. And again, the stronger power should hopefully help with multiple of our associations. And we believe that this data is a starting point, however, in both the development of evidence-based pediatric burn care guidelines for a setting like KCMC, and systems-based interventions, which is what Liz is focusing on in the area. And so I think this is going to coincide quite well with her work, but also a better understanding of the high morbidity and mortality that has been described, like why is this happening and are there ways that we can intervene to prevent it? I'm briefly going to go into the qualitative, although I'll let you know that we're in the process of this, so I don't have findings from this component of the study yet. But as I mentioned earlier, the qualitative component of my study is really going to be using in-depth interviews to investigate how caregivers approach the continuum of burn care for their children. And so we're going to be using a convenient sample of 20 caregivers of pediatric burn patients who are enrolled in the registry, and this will be starting next month. I guess we've started with our first one, so I guess this month, moving into the next. We created an interview guide with our team and developed questions probing thought processes that are related to care-seeking decisions, knowledge about burn injuries, home first aid, care that's received prior to coming to the hospital, and any barriers to accessing tertiary level burn care. And then we are very fortunate that we have a skilled team on site at KCMC, and Gertrude and Keeney has worked with Liz on all of her previous qualitative studies and is very well trained in performing both focus group discussions and semi-structured in-depth interviews. So she's going to be leading this, as well as Nancy and Mary, who is a newer research assistant who has joined our team as well. They're both Swahili and English speaking, so they work with us both for the interview, but in doing translations and transcriptions as well. And then we're going to use a team-based thematic analysis approach and code books as well as memo writing to synthesize this data and identify any patterns. And we're going to try to do this concurrently throughout, hoping to get our goal is to get 1 to 2 IDIs done per month, kind of moving forward from here on out. And hopefully we'll have data later this fall to kind of formalize our findings. I just wanted to recognize that I'm really fortunate. Shannon Anderson is one of our University of Utah Honors College students who is joining our team. So her honors undergraduate thesis will be based off of this work. She works closely with Melissa Watt as well through the Honors College. And so it's been really fun. I went to the University of Utah Honors College myself. And so it's been a nice way to kind of loop back and help someone with their thesis research. So she'll be part of our coding team. And then Happiness Duncan is one of our KCMC master's students who's going to be helping with the coding as well. So getting a lot of involvement from different levels of education. In terms of my qualitative study timeline, we are pretty much just finished with our piloting of the IDI guide. So we're going to be starting IDIs now. Moving forward, which is really exciting, but it's been a process to translate and get our IRB amendments approved. And that just happened within the last couple of weeks. So I think there's gonna be a lot of forward momentum with this part of the project. Cumulatively, we have in our registry 929 pediatric injury patients enrolled, and 120 of them have burns. And that was as of 2 weeks ago. And we are in a combined stage of data collection, analysis, and dissemination. I was fortunate enough to go to the Tanzanian Conference on Emergency Medicine with our colleagues last November to present our initial descriptive data. And I'm heading to the Pediatric Academic Societies meeting in Toronto at the start of May with our updated quantitative data. So in terms of next steps, I'll be in Moshi with Liz, May and June of this year for my next kind of on-site work with our research team. And from a quantitative standpoint, we are currently repeating our analysis with our larger cohort. We're also adding in an analysis with the middle upper arm circumference, which is to measure and assess nutrition, and if pre-existing malnutrition might have an impact on outcomes for these children as well. And then we're adjusting for confounders to strengthen our association between risk factors and morbidity and mortality, as our initial analysis was very, very descriptive. We're also looking at an analysis of markers of sepsis. These patients oftentimes don't have, and I should say rarely have, blood cultures drawn or really any culture data. But as we know that burn patients are quite susceptible to sepsis, we're hoping that we might be able to find some other markers of potential sepsis to analyze and see how that's associated with both morbidity and mortality. And we'll be starting our quantitative manuscript over the summer. And then, as I mentioned, qualitative, we're about to start everything there. And then just from a kind of bigger scope, I'm hoping that all this data will eventually be able to assist Dr. Keating in her further K23 project efforts, which are, it's more of an implementation-based project helping improve access to pediatric injury and trauma care in Northern Tanzania. And I'm sure she'd be happy to talk to us about that here too, because she's on the call. And then I'm hoping that this data will help me in application for early career research grant funding post-fellowship. And I'm very interested in pursuing a global health research career alongside my clinical commitment in the emergency department here in the US. I did want to just kind of pose a question for the group, something that Liz and I had talked about earlier this week at a meeting. And I wanted to take us back to that mention of delays to definitive care and how we had used 4 days as an initial cutoff based off of our bell curve data. As we're rerunning our analysis right now, we have also selected, we're going to rerun that using 24 hours and 48 hours as cutoffs for clinical delay to definitive care. Thinking that from a clinical perspective, I mean, I want children to get there as soon as possible, but in an LMIC setting where delays are can be multifaceted, we figured 24 hours seems like a reasonable time frame to get to the hospital, and 48 hours absolutely so. My question for the group is, and because I have not found anything in the literature, is does anyone know if there is a defined amount of time considered a delay to care for burn injuries specifically? So far, what I've seen has been more of a physiologic description of when delayed care happens. And so there will be like findings with skin healing that can contribute to that. But I haven't actually found a time cutoff, and I'm not sure that one exists, but that is definitely something that Liz and I are interested in, if it exists out there. Here's my list of references, and that is it. I'd love to take any questions, thoughts, probe the group for ideas.